So with these few words about my teachers, I must say that this presentation is mainly based on my personal experience. There may be few ideas which I can borrow from others. And during this process, my family, my colleagues, parents of children, they have also given me certain learning experiences. Let's begin. Whatever we encounter in our pediatric OPD, more than 90% fever, cough, cold, vomiting, loose motion. My child does not eat well. My child is slim. Few surgical problems. I'll not touch the surgical problem because Dr. Kant has recently covered that. So I'll avoid that. We will walk through certain cases and see how do we deal with them. Common emergencies like high fever, seizure, breathlessness, poor urine output, disoriented, accidents. Since I am dealing mainly with OPD practice, I will go into all this because number of these require hospitalization. I am also aware that in general practice or in family practice, there are certain restraints. Usually, now because of COVID, there may be some more time, but otherwise, most of the practitioners have only 2 or 3 minutes per patient. Parents also want a quick response, and we as doctors, as well as the parents, have got a dependence on injection therapy. Doctor साहब injection दे दो जल्दी ठीक हो जाए. How do I go ahead? I have limited time. I have to explain to parents, I have to make a diagnosis, and I have to prescribe treatment. So certain principles can help us. Try to assess whatever mother is telling. Is it really there? Is it a physiological variation? Now, while the child is in your OPD, is the child dull or active? And if the child is really dull, then go for geography, try to localize the lesion. Let's go through some case. Am I clear to all of you? Okay, this was a 4-month-old child, fever for 15 days. Now, the moment mother tells you fever for 15 days, you start thinking, क्या होगा? Typhoid है, malaria है, urine infection है. But child is looking well. When you inquire, there's no cough, no vomiting, no loose motions. Child is taking feed well, and child has a good weight. So when you inquire further कि fever कैसे मालूम आप बच्चे को fever है? Sorry. The mother comes out, the child has warm head. Grandmother tells, अरे उसके हाथ पांव गर्म रहते हैं. पर thermometer से check करो तो temperature is always normal. Certain mothers insist, नहीं, my child has fever, even though thermometer does not say. Now, I usually tell them, beta, buy thermometer of 2 or 3 companies, check with that, and if all thermometers say there's no fever, you have to rely on that thermometer. So is this fever a true symptom? This is another case which I can't forget. 10-year-old child, evening rise of fever for last 3 months. Vidal 1 in 160, therefore treated with anti-typhoid medicines, full course given, no relief. MT was 15/15, X-ray normal, child was started on AKT. Since the child was not getting all right, they were from North India, they brought the child to Bombay. Child was taken to a multi-speciality hospital. Their pediatrician, ENT surgeon, general surgeon saw the child, posted the child for tonsillectomy, cervical and axillary lymph node biopsy. For some reason, the child landed with me, and the first look says the child is healthy. Now 3 months of fever and child is looking healthy. There's something missing. So when I inquired, the parents were executive in the local place. This child used to go to school in the morning somewhere 8 to 1 or 8 to 2. She was the captain of her hockey team and she will play vigorously from 3 p.m. to 4 p.m. She will come back home around 4:15. Mother will put the thermometer, check temperature, it will show 99.5, religiously recorded, and then the temperature chart taken to the doctor. So here, this is a physiological variation post-exercise rise in temperature, which does not require any treatment except the assurance to parents. Let's go further. 2-month-old child, mild fever for 1 day. But someone suggested CBC CRP. CRP came 70. Now, in a 2-month-old child, as a pediatrician, if we find such high CRP, our protocol is that we must admit the child, do a lumbar puncture, rule out pyogenic meningitis. But this child, when child was kept on my table, child was clinically active, child was looking well, even social smile was present. What do? I did not feel like doing an LP for that child. So we just repeated CRP, another lab where I rely more. And within few hours, we got the report CRP was normal. So lesson was that treat the child and note the report. If your child is looking okay, reassess the reports. Another child here is a bit different. Same 2-month-old child.
Sir, can you fever, speak a bit looking, louder, sir?
High CRP.
Louder, yeah. Thank you.
Okay. Now?
Yes, yeah.
So 2-month-old child, high fever, sick looking, high CRP, polymorphonuclear leukocytosis. Now this picture itself tells you there is some infection and most likely a bacterial infection. But I could not find any localizing sign. So I said, come again. The child got admitted at some other nursing home the same night because of high fever. Child was started on antibiotics. After 3 days, the mother complained, Dr. Saab, there's a lace movement in the right shoulder, and it turned out to be right side shoulder abscess. Similar case, 1-month-old child. Child was brought for fever for 1 day and excessive crying. So when the child is brought with excessive crying, we remove all the clothes of the child, examine from head to toe. So we did that. But that particular day, I did not remove the nappy. I just gave symptomatic treatment. Next day, grandmother brought the child and she told me, Doctor Saab, यहाँ पीछे कितना लाल हो रहा है देखो. And child had severe cellulitis at the sacral area, which I missed. And that was the reason for fever. So 2 lessons to be learned here, that whenever you are not able to localize, look at hidden areas like shoulder, like nappy areas. I must tell you, though it's not related to fever, a child was brought with excessive crying. I could not find anything. We just turned the child and there was a needle sticking inside the back. Needle removed, child got relief. So keep in mind, if a child is excessively crying, remove all the clothes and check. The second point to be learned here is do not ignore whatever mothers or parents are saying. So if she said there's a lace movement of right shoulder, we cannot ignore it. Another common system, 12-year-old child, fever, high fever for last 4 to 5 days. It's mentioned here fever with throat infection, that's a sort of a diagnosis given. And therefore, the family doctor prescribed this. You can see 4 medicines here and another 2 or 3 medicines here. I can understand the concern. Fever, immediately one starts thinking, is it COVID or not? And maybe Advent was given as a regular antibiotic, azithromycin was given for COVID. But anyway, 7 medicines to take, first of all, is not practical. And did the child really need all this? So when we went into the history, child had fever, which was gradually coming down. Child had high fever to begin with, but the intensity of fever was coming down. The frequency of temperature spike was coming down. Coughing was only mild, and on an examination, not anything wrong. This child also had brought the CBC report, which you can see that WBC counts are normal, platelets are normal, and neutrophils are 62. So overall, this report is within normal limits. This report does not suggest anything like bacterial infection. And therefore, one could do only with paracetamol. Of course, child got all right in another 2 to 3 days. The next question which comes, and we all have to answer that in today's time, is it COVID? Is it COVID-19 infection? In our building, we have a person who is COVID-19 positive. Is this child COVID positive? How do we answer that? First thing, we need to explain to parents that there are no specific symptoms of COVID. COVID-19 is a viral infection. It will behave like other viral infections. So there are no specific symptoms. And just by clinical examination, we cannot make out who is COVID or who is not COVID. Then the next is, should I do the COVID-19 report or not? If the parents are keen, it should be done. Secondly, if they have a person who is aged, 60 years, 70-year-old, or a person with comorbidity in the same home, this child should be tested because this child can become a source of spread of COVID-19 infection to the older person. Otherwise, in case parents want to skip it, there is a unit family. I presume if one person is COVID positive, the other two will also be. So if possible, in such a situation, one may do COVID-19, but if one wants to skip, one can. So at this stage, we must try to differentiate any child who has fever. Is it viral? Is it bacterial? Can we do that? There are certain guidelines which definitely help. If child has high fever to begin with, and over a period of time, temperature spikes are going down, more likely to be viral. If child has associated running nose, watery red eyes, more likely to be viral. If child has cough, loose motions, that means respiratory system is involved, GI system is involved. GI system is involved, it's more likely to be viral. But more important than all this, what I think, if child is very inactive between temperature spikes, it's more likely to be viral. Usually in a bacterial infection, child still remains sick even when the temperature comes down. If more than one family member affected, more likely to be viral. And when you examine, there are no localization. So it's more likely to be viral. Another point which helps, this particular year, sickness has been less. But every year, we used to talk, fever OPD chalu hai, fever OPD chalu hai. So whatever kids you see in your OPD, majority are with fever, it's most likely to be viral. So viral fever with running nose, with rash, and then points in favor of bacterial. In bacterial, to begin with, fever may be less, but over a period of time, intensity keeps on increasing. And child is sick between the temperature spike. When you examine, you are going to do a systematic examination, throat, lungs, tummy, the hidden areas. So if you are able to localize, more likely to be bacterial. And usually only one system is involved. The child is looking sick, more likely to be bacterial. Now let's look at this child. 4-year-old child, fever for 3 days. no cough, no loose motion, no urinary complaints. And on examination, no localizing signs. CBC shows leukopenia, relative lymphocytosis. So overall picture is suggesting it to be viral infection. But urine routine showed 30 puzzles. Can I ignore it? Do I call it urinary infection? More than 10 puzzles in a midstream urine sample is significant. So here it's a significant pyuria, but that is not equal to urinary infection. By definition, child should have some urinary symptoms, and the colony count, when we do urine culture, colony count should be significant. Just presence of pus cells in urine does not mean urine infection. Therefore, I don't start the antibiotic immediately. I'll request the parents to do a urine culture colony count antibiotic sensitivity test. And then once they've given the sample, I'll start the antibiotic. Usually an antibiotic which covers gram-negative infection, like cefixime. Here we have another child, fever for 7 days. On examination, no localizing symptoms. And child is active between temperature spikes. CBC within normal limits and Vidal is 1 in 160. Now how do I proceed? Fever is for 7 days, parents are worried, Vidal is come positive. So do I start the medicine for typhoid? Most likely by the time child comes to us, the antibiotics have been already started. So do I staple the antibiotic? Do I hospitalize this child? Now we are basing our diagnosis only on this Vidal report. There are limitations to the Vidal report. Both Vidal and typhoid test are immunological tests. Now, when we interpret, we must keep in mind that Vidal has a very low sensitivity and low space. That if there are 100 blood culture positive typhoid fever cases, it may pick up 70%, 80%, but it will still miss 20% cases. Specificity means that if there are 100 negative cases, Vidal should show all them to be negative, but Vidal does show number of cases as false positive. And therefore one cannot rely only on Vidal. There are certain things which one can do in 1 week, while typhoid test can be done in the first week of fever. The titers 1 in 80, 1 in 160 may be because of abundance of typhoid infection in our community. But if you see O titer 1 in 320, it may be significant. But number of times we see O, A and B are negative, but H is 1 in 320. That should not be taken as positive, because Vidal H titer will rise with any infection. So that should not be considered at all. Typhoid, as I told you, has an advantage that it can come positive in the first week. It has a good negative predictive value. That means if typhoid IgM is negative, the chances of the child having typhoid fever are less. But it does not have a good sensitivity, specificity. So again, we come back to it. For diagnosis of typhoid fever, one should rely more on clinical judgment, fever, gradually increasing, sick looking child, appetite has gone down, activity has gone down, and on examination you may find liver enlarged, spleen enlarged, and then send for a blood culture. Here on clinical grounds you can start an antibiotic, but the blood culture report will take 3 days. But your diagnosis should not be based only on Vidal or typhoid. Another case. 6-year-old child, high fever, severe muscle pain, no localizing signs. But CBC shows polymorphonuclear leukocytosis. Now, initial picture fits into viral, but here, how do I take this polymorphonuclear leukocytosis? Friends, keep in mind that even in viral fever, on the first day, one may get polymorphonuclear leukocytosis. So usually we do not ask for a CBC on the first day. Secondly, if you see a leukocytosis, which is polymorphonuclear on 4th day or 5th day, and there are no localizing signs, keep in mind urine infection, pus somewhere in the body. Thirdly, try to look for other things like liver, spleen, and we can tell parents that we cannot make a diagnosis just at first look. Usually I give them an example that if there's a theft at home and you call a police person or a CID person, they don't give you the thief right on the first day. So give me time to assess, we'll reassess tomorrow. And in this case, over the next 2 or 3 days, child develops jaundice and hepatomegaly, which could suggest infective hepatitis, but polymorphonuclear leukocytosis will go against that. This case turned out to be leptospirosis. Of course, in other cases, one should look for occult pneumonia also. And this one more condition will come across in the next case. Here is a 2-year-old child, high fever for 5 days, running nose, red eyes. But child remained irritable even when the temperature spike subsided. And as usual, no localizing signs. CBC showed polymorphonuclear leukocytosis. So here I have a child for fever who is irritable, who has running nose and polymorphonuclear leukocytosis. We have already discussed that we must look out for all this, but look at the last line. We should think of as something called Kawasaki disease. Kawasaki disease is also called as mucocutaneous lymphadenopathy because they have fever, they are irritable, they usually have some rashes, some lymph node enlargement, but which one may or may not notice initially unless you look for them, and therefore one needs to keep this in mind. Another interesting case, 10-year-old girl, she had fever a few days back. She had no urine symptoms, but urine routine showed 15 to 20 pulses. As we discussed earlier, more than 10 pulses in urine is a significant pyuria, but it does not mean urine infection. So urine culture was asked for. And urine culture showed Proteus mirabilis, colony count more than 1 lakh, which is resistant to majority of the antibiotic. This child was advised hospitalization and parenteral antibiotic. Now when the child comes in your OPD, child looks absolutely hale and hearty. Child has no urine symptoms. So I have two things. One, child has asymptomatic significant bacteriuria. Do I treat it? Secondly, urine routine culture is showing Proteus mirabilis. I have to take it with a pinch of salt. So how do I manage? I just requested parents that we need to repeat urine culture. And we did a repeat urine culture, but ideally one will do a midstream urine sample. But here parents wanted to be extra sure. So one can either do a catheter sample, but in case child has a true urine infection and I put in a catheter, I may spread the infection. So here after discussion with parents, we did a suprapubic urine collection and urine culture report absolutely normal. And this child did not need any medicines. This is coming now to the treatment of fever. And this slide I've specially kept. There are basically 3 medicines for fever: paracetamol, ibuprofen, mefenamic acid. And how do we remember the doses? Mefenamic acid 5 mg, ibuprofen 10 mg, and paracetamol 15 mg per kg body weight per dose, and can be repeated 4 to 6 hourly if required. But we must remember, do I prescribe 6 hourly medicines? कि हर 6 घंटे से दवा दे दो? Usually what I tell parents, do not use that. Use them on an SOS basis. First thing, child should have fever. Secondly, I am not trying to treat fever. Only if fever makes your child irritable or dull, use antipyretic. If I keep on giving every 6 hourly fever medicine, there will be a false sense of security that fever has subsided. We must avoid combination, like combination of ibuprofen with paracetamol, combination of mefenamic acid with paracetamol. This only masks the diagnosis, delays the diagnosis, and all medicines have some side effects, like ibuprofen and mefenamic acid may give nephrotoxicity, which we may not realize that particular time, but as the child grows older, we will come across. Gastritis, mefenamic acid is known to give GI bleeding, so please keep in mind that avoid combinations. Now parents will ask, डॉक्टर साहब पर ये फीवर आ क्यों रहा है? ये अप एंड डाउन होता है, टाइफाइड तो नहीं है. So usually, now here I'll again remember Dr. Athawale. We need to go to level of our parents, at their cultural level, at the education level of not only parents but grandparents. So theoretically I may not be right, but I usually explain them that we boil milk at home. Purpose of boiling milk is to kill germs. Similarly, when disease germs enter into our body, our nature boils our body to kill those germs. And until the enemy leaves our home, fever, like a true friend, will remain with us and will try to kill those germs. So do not run after fever. Fever is a person who is helping us out, or fever has come to work for us without salary. So accept fever and remember that it will help to eliminate the infection. Next question, but डॉक्टर साहब 103, 104 बुखार जाता है. We must remember high fever does not indicate seriousness of illness. As we discussed in viral fever, to begin with, fever temperature spikes are high. Over a period of time, they go down. The next thing parents are worried कि fever सर पे चढ़ जाएगा, febrile convulsion आ जाएगा. Now see, one, we know that number of children do get febrile convulsion. In fact, nearly 2 to 3% of children under 3 years will get febrile seizure at some time or other. But I explained to parents that why do convulsion occur? Again, my explanation from their point, not medical point, is that this brain is an electrical powerhouse. When the electricity comes from here to my fingers move. But when for some reason this powerhouse sends more electricity, we get convulsion. So to elevate their tension or anxiety I tell, next second you or me may get a convulsion, because by definition convulsion is a sudden, unpredictable event. But fortunately in a child, when it comes with fever, Though it is scary, it does not cause any harm to the child, immediate or long term. Therefore, we explain emergency management of fever and seizure to them and try to take away the tension factor. We must remember that before we start any antibiotic, fever does not mean antibiotic. We must try to analyze its bacterial infection or viral, and otherwise give some time. Dr. Amdekar usually says that by delaying starting antibiotic, of course he has nearly 50 years of practice or maybe more than that I have not faced any problem. By delaying starting antibiotic in a child, I have not faced any problem. We are now switching over our gear to another symptom, cough and cold. Again, the same story. When parents tell you that child has cough, is it really cough and cold? In our country, अगर बच्चे ने उल्टी किया, उसमें कुछ स्टिकी निकला, डॉक्टर साहब इतना सारा कफ निकला, फिर भी मैं कहता हूँ एवरी स्टिकी थिंग इज नॉट, नो डॉक्टर साहब ऐसे ऐसे चिपचिपा चिपा निकलता है. सो दे आर कन्विंस्ड दैट इट्स कफ. अभी उल्टी का छोड़ो, अगर मोशन में भी स्टिकी आया तो इट्स कफ. सो यू नीड टू आस्क व्हाट डू दे एग्जैक्टली मीन बाय कफ. The number of children have ghor noise in their chest, which in our words we call it congenital laryngeal stridor. But for them, it's cough. And then the child receives bronchodilators, child receives antibiotic. We must remember that whenever such a complaint is there, ask them, how badly is your child coughing, is having bouts of cough? And good number of time the answer is just occasional cough, occasional sneezing. So this ghur noise is not a true cough or cold. Sometimes when green color of the motion, grandmother interprets as cough. That also is not true. Or sometimes they interpret it as cold. Now here I have a 9-month-old child who is presented with fever, running nose and fever for last 2 days. Cough gradually started. Fever, cough and cold came on the same day. Child is active in afebrile period and similar complaint in siblings. So this is a typical history of a viral infection. And the ideal treatment is plenty of liquids orally, antipyretic agent when required. Here use of antibiotic will not help. On examination again, child vitals were stable, no respiratory distress, child had congested eyes, nothing more. On the other hand, this is a 10-year-old child coughing for last 1 month. No fever, no breathlessness. And child has already received 2 courses of antibiotic. This is another thing. Dr. Amdekar used to say, if child has come to you with 2 courses of antibiotic, which are adequate dosage for an adequate duration, do not think of a 3rd antibiotic. Think of revising your diagnosis. Now here on history, the parents came out, the child coughs only at middle of the night. Throughout the day, there is no cough. And the timing was so specific, night 2 a.m. to 4 a.m. So this is a nocturnal cough coming at a specific time, and it's an hyperreactive airway, or you may call it allergic cough. Use of an inhaled bronchodilator, which is long acting, with inhaled corticosteroid at night, resolve the problem. Another one, 8-month-old child, cough for last 8 days. Now origin, duration, progress. The child's cough started suddenly, not gradually. And since that time, it has been persistent. But then no fever, no running nose, no breathlessness. no family history of asthma, and it's a full-term child. Now here, remember 8-month-old child has a tendency for oral gratification. Child will try to put each and everything in mouth. So one must suspect a sudden onset cough in a foreign body. And in this child, X-ray chest did show a foreign body. 4-year-old child, fever high grade. I mentioned here, query plus minus cough for last 4 days. Child dull even in interfebrile period. The moment we say dull even in interfebrile, you may have to think of bacterial infection. Then try to localize the symptom. Here it was easy, the congested throat. But in some cases, even that may not be there. Examine lungs properly. In a busy OPD, if you are not able to do, ask for a chest X-ray. NCBC, of course. 14-year-old girl, fever, cough going on for last 10 days, loss of appetite. But the parents specifically said that child has been losing weight. Child has already received 2 courses of antibiotic. Again, my stress is there's no point in adding third antibiotic. There's no point in stepping up antibiotic. Investigate this child with fever, cough for 10 days, with loss of weight. Start thinking of tuberculosis or some infiltrative disease in the lung or malignancy or HIV. So any prolonged fever, one should start thinking of this. Number of times history tells us some clue. If there is a cough throughout the day, but the rest of the child is well. But on inquiry, you find that cough is there only at feeding time and not at other time. So this cough is related to swallowing. And maybe the child is trying to swallow very fast and is getting cough. Just assurance to parents may help. Frequent bouts of cough after lying down, especially after meals. So no cough in the daytime. So especially for children who take late night meals and then immediately try to go to sleep, one may face this problem. It may be gastroesophageal reflux disease, more common in obese. We know what are the common causes. First and foremost, infection. It may be viral, it may be bacterial, it may be tuberculosis. Allergic is another big chunk of cases. Foreign body, irritants, and psychological. This is another thing which helps. If cough is the dominant symptom, think of airway. If breathlessness or fever is the dominant symptom, think of lung parenchyma. And if chest pain is a dominant symptom, think of pleura. So while you have a cluster of symptoms, try to find out which one is more dominant. We know cough with fever, think of infection. Cough only at a particular time, like I mentioned, cough between 2 a.m. to 4 a.m., likely to be allergic. Cough only in daytime, but no cough during the night. Think of psychological. Cough only at feeding time, swallowing. Another common symptom, vomiting. ये बच्चा तो दिन में 5-6 बार उल्टी करता ही है. जब भी खाना लेके जाओ उल्टी कर देता है. Now the child otherwise looks well, but child is vomiting. Do antiemetics help here? They will not help. Because child over a period of time has developed aversion to food. I have seen kids who with the sight of milk bottle will vomit. I've come across one child who used to vomit at the sight of mother also. So we need to explain that one should get out of this force feeding. Now I'll come to it, the detailed explanation when we come a little later on poor appetite. Of course, all of us may get sensation of nausea if we do not like the taste of food or smell of food. Of course, we have to think of gastroenteritis, food allergy. milk allergy is one of the common allergen. Reflex vomiting, and then we must keep in mind surgical causes or some real problem like raised intracranial tension. We'll not go into those details because I am focusing only on common problems seen in OPD practice. Loose motion. Again, usually I put down these 5 causes: infection, food allergy, malabsorption, medicines, and irritable bowel, which one may call it even a psychological thing. Now let's take this example. 9-month-old child presents with fever, cough, cold, loose stools for 4 days. Fever subsided after 2 days, but the cough persisted. Loose stool started on day 3 of illness. Child has adequate urine, child is being breastfed, and is on complementary feeds. Now, how do I assess? The fever has subsided, child is looking well. Most likely I am dealing with viral. How do I explain loose stools? Do I start an anti-diarrhea medicine? Now here the history was that on day 2, amoxicillin clavinic acid combination was started, which is quite a common practice in our day-to-day practice. And clavinic acid is known to give rise to loose motions. So first of all, the child did not need an antibiotic. Secondly, the reason for loose motion was clavinic acid. Another thing, when we prescribe antidiarrheal, think about it. Does the child really need any antibiotic? Now, a point to be noted that in an exclusively breastfed child may pass 15 to 20 motions per day or may pass 1 motion in 4 days. Both are normal. A breastfed child may have yellow motion, greenish motion, sometimes even with mucus, sometimes even with froth. But if one is sure that child is being exclusively breastfed, child is otherwise healthy, child has a good urine output, we need to explain that these are normal for a breastfed child. But let's say we are facing a real problem. Child is having 20, 30 watery loose motions in a 6-month-old child or a 9-month-old child. How do I manage? Now, first of all, my counseling. I explain to parents that we have this intestine, we have this pipe, there is a mouth here. After 4 months of age, child starts putting everything in mouth. Something has gone in which nature does not want. So what is the way to remove? There are only 2 orifices. Either child will vomit out or will have loose motion. Now, if I put a booch here and a booch here, the intestines will not get clear. And therefore, the treatment of loose motion or vomiting is not to put a stop to that immediately. Whatever antiemetic I am prescribing, it will only do this, that if there are 10 vomits, it may make it 5 or 6, but it will not stop it. For loose motion, my treatment will remain कि इस पाइप में ऊपर से डालो नीचे से निकले, ऊपर से डालो नीचे से निकले, and therefore ORS. Now ORS can be commercial ORS, can be homemade ORS. What is the role of zinc? Number of scientific papers trace on role of zinc in men. That's my personal opinion, that for a 2 or 3 days of loose motion, zinc may or may not be necessary. And some kids may not like the taste of zinc preparation. So if you are prescribed when child does not like, it's not mandatory to give it. Probiotic I do prescribe, but again, not an established line of treatment. I usually prescribe it as a placebo because parents want some medicine. Anti-motility agents definitely contraindicated. Of course, these days, I don't think any preparation has anti-motility if medicines in them. Earlier, one used to use Imodium, Lomotil, opium, but all of them are now out. Antibiotic. What are the indications for use of antibiotic in a child with loose motion? If loose motions are with blood or with lot of mucus or with high fever, then one should go for an antibiotic. Otherwise, majority of watery loose motions do not require an antibiotic. Here again, something from my heart, that we do see a number of children where one has been prescribed a combination of an antibiotic with metronidazole, or this stage even another anti-MABs are available. First of all, watery loose motion, no chemicals required, no antibiotic, no metronidazole. Second thing, amoebic infection in small children is not common. So if you are giving, give only antibiotic, not a combination. And third thing, when you use metronidazole or similar preparation, tinidazole or others, it increases chances of vomiting. So child already has sensation of vomiting and you are increasing that chances. Now, poor appetite. Again a common problem, डॉक्टर साहब कुछ तो दवा दे दो कि मेरा बच्चा ज्यादा खाए. या तो पेरेंट्स कहेंगे या ग्रैंड पेरेंट्स कहेंगे, but they want some medicine. And we know that number of medicines are prescribed according to increase appetite. I'm aware that in few cases it does increase appetite. But is that the answer? If a parents tell that my child has poor appetite, first thing ask, is your child acting? Then assess with the growth and development. If these two things are okay, and on examination we do not find any significant illness, then what it requires is a good counseling. And even at the cost of some time, I'll talk about this counseling factor. First thing which I tell parents is that in the first 1 year, child puts on about 5 to 6 kg weight in the first year. Thereafter, from 1 year up to puberty, the weight gain is 1.5 to 2 kg per year. So पहले आपके बच्चे को फिक्स डिपॉजिट में ज्यादा जमा करना था, अभी कम जमा करना है, तो उसकी रिक्वायरमेंट कम हो जाती है. Second point is that at 1 year, kid enters into phase of negativism. If we try to force something on the child, even if the child is hungry, child will do just the opposite. We were talking of the reason for vomiting, they are force feeding. So if we try to force feed the child, child will do the opposite and will throw out the food. Third thing, child also enters into phase of imitation. हम खिलाएंगे तो नहीं खाएगा, but child is observing grandma क्या खा रही है, उसी की प्लेट में जाके खाना है, वो भी दादी के हाथ से खींच के खाना है. If she is eating mirchi, child will pull that. So phase of imitation. Or some kids will play sort of holy with the food, that you give the food in plate, but they will put it on the floor and then pick it up and try to eat. So we will have to allow all this. And still the parents are not getting convinced. Then I convey to them that what is the purpose of putting petrol in the car or diesel in the car? That car should run. Now, if any car consumes less petrol or diesel, still runs efficiently, are you going to be happy or unhappy? So if our body consumes less food and still remains active, that means God has given us a good engine. Do you, as a doctor, prescribe some medicine which will spoil the engine of your child? Now, most of the time it helps, but still, after having explained all this, after telling the full Ramayana, the डॉक्टर साहब खाना तो खाना ही चाहिए, मेरा बच्चे का काम कैसे चलेगा इसके बिना? In fact, one of the grandmothers got so angry at me because the child was 14 kg at 1 year, looking so obese, And her complaint was, my child does not eat. So I said, आपके बच्चे को डाइटिंग की जरूरत है, खाने की जरूरत नहीं है. So grandmother got so angry, she just walked out. But whatever is the fact, we need to explain. One of the reasons for taking less food is also child is consuming a lot of milk through bottle. Some kids may be consuming 1 liter, 1.5 liter. Then whatever petrol the car needs, it has come through milk. How? There will be no place for other food. So we have to keep all this in mind before prescribing any medicine for poor appetite. We have already covered this. So one more thing which comes, my child is slim, especially around the age of 5 to 6 years. Give some medicine which will make him put on weight, some tonic, something which will healthy lage bacha. Now here I explain to parents that I can only assess for disease. If I find a disease, I can treat that, and then your child will put on weight. But otherwise, if your child is active and playful and child is slim, maybe the child's constitution is like this. Now, from the point of assessment, I do ask, has any one of the parents has been slim during early childhood? Which even though the parents are chubby or obese at this adult age, if one of them has been slim in their early childhood, there is a good chance that constitutionally child may also be slim. Second thing I explain to them is that if God has made my this finger small and slim, by medicines I cannot make this finger like this. So purpose of so-called tonics और ताकत बढ़ने की दवा only increases the strength of pharma company, not your child's strength. And therefore, focus on finding the disease and then treat. So friends, in simple words, take home message, try to make a provisional diagnosis. Ideally write it on the paper, but if not, at least keep it in your mind. Investigation should be as per need. When we write blindly various panels, they may confuse us more. Of course, it will mean more expenses also, but they may confuse us more. Like a lot of fever panels have, you send the child on 4-day fever panel includes Vidal. Now, doing a Vidal in the first week is of no use. Use minimum medicines, and beside medicines, spend 1 minute on counseling. Well, if you tell the parents that this particular illness may take 3 days or 5 days, they are ready for it, and they don't end up on the second day itself to tell you कि डॉक्टर साहब आपका दवा तो काम ही नहीं करता है, डॉक्टर साहब ने एंटीबायोटिक दे दिया फिर भी ठीक नहीं हो रहा है. So a proper explanation will be helpful, and try to put, as my teacher used to say, Dr. R.K. Anand, yourself in patient or parent's shoes and then treat. That will help us. There are indirect benefit of whatever we have discussed. It will avoid polytherapy and therefore avoid number of side effects. It will reduce the cost and it will avoid antibiotic resistance. And if parents are satisfied, here my customers are parents, they will bring in more patients. And once we go through these basics, like what Dr. Amdekar conducts TR programs, that most of the illnesses we can simplify in our mind, try to reach to a diagnosis, then each one of us is capable of managing 95% of the illnesses. With this, I say thank you to all, but I have specifically cut it down my presentation so that I can answer more questions.
Thank you, sir. Now, whoever has questions, if possible, put it on the chat box. So, sir is here to take questions now. Whatever questions you want to ask, preferably put it on the chat box or raise your hand so that I can unmute you. Any questions?
I think the family doctors feel that this is not a practical thing.
Sir, it was wonderful.
Uh-huh.
Dr. Hema here, sir.
Hema Saha, see, you are yourself a pediatrician, so your perspective will be different.
No, sir, I am Dr. Hema, the anesthetist.
Acha, 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 acha.
Sir, I reminded of your lecture 30 years ago. It is the same thing.
Uh-huh.
Beautiful.
તો 30 વર્ષમાં નોલેજ વધી નથી, ત્યાંની ત્યાં છે.
ना, same, the basic principles remain same. BMR वही रहता है.
Yeah, so I think there are some more questions. Dr. Vittal Velubi is asking, a child comes with abdominal pain and sonography shows mesenteric lymphadenitis. How to handle?
Hello. This is again a common report. Now, abdominal pain can be due to various reasons. And let me tell you, how do I explain to parents? That the common causes for abdominal pain are some infection in the body, in the tummy, which will then abdominal pain will be associated with vomiting or loose motion. Second reason is food allergy. There, if you look through it, one may find some history that after a particular food, child gets tummy pain. Third reason is constipation. Child has an urge to go for motion, but stops it due to some good cartoon or cricket ka match chalu hai for whatever reason. Third is force feeding. Child does not want to eat and mother is trying to force, one gets tummy pain. The fifth is any tension factor, even in a child, can manifest as tummy pain. And the sixth reason, attention seeking. Now, these are the usual causes for tummy pain, I tell. But as the question which you asked, multiple mesenteric lymph node, first of all, if there's any infection in the intestine, it can be simple gastroenteritis, it can be enteric fever, the mesenteric lymph nodes will get enlarged. So enlarged mesenteric lymph node does not mean tuberculosis. So if you have a persistent abdominal pain for a long time, you find lymph nodes, the size of the lymph node, various people tell different size, but let's take more than 15 mm in a transverse diameter, and these lymph nodes are necrotic, do think of tuberculosis, but that will require confirmation by doing a laparoscopy and preferably doing a lymph node biopsy. But just because the child has mesenteric lymph node, it does not mean tuberculosis. The other thing which I find is that in our day-to-day practice, parents get sonography done first and then they come for clinical assessment. It should be reverse clinical assessment, then if required CBC, urine stool, and then one thinks of sonography. Sonography is quite lower on the ladder. It should not be the first test to be done. Does that partly answer your question?
Yeah, that is one thing. And there is Dr. The next question is by Dr. Kaushik Shah. He's asking for treatment for heart stools.
Okay. See, again, a common problem. The child has hard motions for 15 days, for 1 month, the first and foremost thing is to pay attention to diet. Is there adequate fiber in the diet or not? And next question I ask is, how much milk does the child consume in a day? So the parents usually come out half liter, 1 liter, 1.5 liter. So I give them a list of items which one should avoid. That one must cut down on milk and milk products. Avoid apple, pomegranate, banana in some cases, and all maida product, which will include biscuits, white bread, noodles, pastas. Avoid chocolates and avoid any refined food. The another common thing is various sort of tonics or powders. So avoid Bonvita, Complan, Horlicks, Pediasures, and then or any iron or calcium medicine can also give rise to constipation. So we need to avoid all this. Having explained them diet modification, I also need to tell what to give. So I convey to them that give more of papaya, muskmelon or kharbuja, watermelon, pear, chiku, grapes, anjeer, among dry fruit, kismis, khajur. Then try to add lots of vegetables in the rice and khichdi, whatever they prepare. So this is from the diet point. Now there are certain preparation medicines available like Mecragol, or it's available with the name of Egilex, which one may use to disimpect whatever hard motions are there in the tummy. And then one may continue with lactulose. In some cases, even cremafin, etc. Though cremafin is not advocated by a number of people for time being. But I stress on parents, medicines are not the solution for constipation. They are only for a temporary buying time for you to change the diet. And there will be occasional case who will need surgical help, but most of the cases will get all right with diet modifications.
Yeah, and also, sir, regular toilet training and sitting position.
Regular toilet training is not so easy for kid. If we force it, child develops an aversion. So we have to keep on just explaining, and kids will learn by imitation. So at this time one should go, one should, and in case child makes certain mistake, we can't scold the child because scolding will again put a fear in the child's mind. So it's going to be a gradual process.
Yes. So another question by Dr. Kaushik Shah is, a child has to pass stool after every eating episode. So how to manage?
Okay. See, this may be because just a gastrocolic reflex. One has to go into the emotions are well formed or not. The second thing is certain food items child may not tolerate. But number of cases, if it is an older child, 6-year or 8-year-old child, it may be related to amoebiasis or giardiasis. So one may give a course of antimicrobial like metronidazole or tinidazole. And still if it's not okay, then of course one can try enzyme preparation, but it's not an easy. Number of kids do not get relief easily. I'll start looking for even psychological reasons or any tension factor in the child. It may be just an irritable bowel. So look for other causes.
There's a Dr. Pradeep Dani is asking, child 7 to 8 years old with only presentation weakness, does not feel like playing or studying. Any psychological illness? Please throw some light on psychiatric problems in general practice.
So, I think that's entirely a different topic. And honestly, I may not be tuned to that. But I can only tell you that psychosomatic problems are quite common in day-to-day practice. So if the parents tell you certain complaint or the child tells you certain complaint, like abdominal pain, headache, tiredness, and on physical examination, we do not find anything wrong, start thinking of psychosomatic problem. Like recently, I had a child, 10-year-old child, with lot of problems, some altered behavior. And since I did not find anything, I told parent, to me it looks like psychological. So we need to assess from that point. While leaving my room, the mother tells me, डॉक्टर साहब ये प्रॉब्लम पिछले 2-3 साल से ही है. जब से छोटा बच्चा घर में आया, he has started behaving abnormally. So one of the reason can be sibling rivalry. And the other thing is during this COVID-19, when the kids are not getting time to interact with other school kids, with their building friends, this is also giving rise to a lot of psychosomatic problems.
Dr. Mitesh Vora, he is asking, in allergic conditions, there is unnecessary use of steroids and anti-allergic medicines, which ultimately suppresses the disease and the child lands up with complications. Why can't we refer the child to alternative treatments like homeopathy?
Okay. See, I do tell parents that all pathy they are practiced properly. I am nothing against homeopathy or Ayurveda, but I am an allopathy doctor. I can only advise you as per allopathy. Now, there are certain cases which I do refer to homeopathy, but I tell them it's both ways. Number of homeopathy doctors bring their kids to me. So whatever works for a particular child is quite okay. I also know, like Dr. R.K. Anand's son is a homeopath. Now, though Dr. Anand is an allopathy doctor, at their home, now for last, I think 25-30 years, they have not used any allopathy medicine, they rely only on homeopathy. So homeopathy also gives good result, and it's only parents have to take a call, where do they want to go. And for allergic, it's not that allopathy does not have an answer. If we go into the proper detail, instead of just writing antihistaminics or steroids, like as I explained you that nocturnal cough, which is coming at 2 a.m. to 4 a.m., if I just give a bronchodilator, which also long acting along with steroid, it does help. So anything practiced properly is useful. And I have nothing against referring to a homeopath or Ayurveda. It should, as long as it benefits parents.
Dr. Shilpa Pandey is asking, let us know how to explain parents about precocious puberty.
This is just how to explain to them. I think the topic totally changed ho gaya hai. It requires a lot of counseling things. Now, in my OPD, usually I don't do this because it will require sex education of children. And I'm sure there are other people who are better at it. Neeta, if any one of you can answer it better.
Yeah, I think when we diagnose it as precocious puberty, the child psychologist, the gynecologist should come into picture, and they would be better people to explain the physiology of the body. Right, sir? And the next question by Dr. Vijay, treatment of thumb sucking in infant.
Now, thumb sucking up to a particular age is a sense of emotional security to the child. Now, that particular age limit can vary from people to people. I usually take it 3 years as a cutoff period. But thumb sucking itself carries that the teeth may have malocclusion later. So whenever child is doing thumb sucking, we try to divert the child's mind from the thumb. Usually kids will do thumb sucking when they are hungry, when they are feeling sleepy, or at a later age they are feeling bored or they are anxious. And therefore, we try to address to these issues as far as possible. Still, it's existing, one can put some irritant around the thumb, or one can tie a sticking plaster. But in a real situation may be there when none of these things work. People, even the dentists, have tried to put some sort of wire mesh at teeth so that the thumb does not go in and only some semi-solid food can go in. But if the child is keen for thumb sucking, it may even bring that out. So the treatment will be try to go into the issues. Why is the child doing thumb sucking? If there is an emotional security problem, we have to give alternate emotional security to the child.
Dr. Kinjal is asking, for infantile vomiting cases, what should be done?
I think what you mean is around 1 year or earlier.
Yes, sir. Around 3 months to 1 year.
3 months to 1 year. See, number of kids have gastroesophageal reflux. So if a child is vomiting, but child is otherwise thriving well, child is putting on weight, child is passing urine freely, child has good development, and on examination we do not find anything wrong, I usually draw the diagram of esophagus, stomach, and explain them about gastroesophageal reflux. But if the growth or development is affected, which then I look for alternative causes for vomiting, which of course the list is quite long. But in majority of cases, the parents bring the child with 3, 4, 5 vomits per day, and it turns out to be GR. Around 1 year of age, it may be force feeding, or even maybe a bit earlier also, 7, 8, 9 months, that child does not want to eat, but somebody has told that at 6 months we have to start semi-solid. Somebody has told that we have to give 2 or 3 meals per day. So that food is being forced on the child, then child will vomit.
Question from Dr. Hema.
Thank you, sir.
How do you counsel
Thank you.
continuing outside milk or excluding the milk from diet?
We have a sort of perception in our mind that milk is absolutely necessary for the child. And I do remember one situation. Of course, I used to practice late at night at some time. So at 10:30 p.m., some mother came inside my room and saying that what is the problem? Mera bachcha doodh nahi peeta hai. That is the only complaint. The otherwise child is quite well. So I said, for that problem, what was the need to come? She said, I came with some other friend here and आपकी क्लिनिक में बाहर पोस्टर लगा हुआ है कि बच्चे को रोज इतना दूध पिलाना चाहिए. Now, even I was not aware of that. Some pharma company had come and put that sort of a poster, and it gave that impression to the mother. So we may carry a number of impressions that milk is absolutely necessary. It's necessary for proteins, it's necessary for calcium. But we must also remember that we cannot force the child to have milk. There are alternative sources of protein and calcium available which can be used. And when I talked of constipation, that we need to eliminate milk from the diet, when I talked of that my child is not eating any solids, I talked of removing excess of milk from the diet, is the parents should, पर बच्चा छोड़ता ही नहीं है, बच्चा तो जिद करता है. My final answer comes to them कि कोई भी आदत छुड़ाना हो, एडल्ट्स को सिगरेट छुड़ाना हो, so even in this case बच्चे के साथ और उससे ज्यादा आपको अपने दिल के साथ महाभारत करना होगा कि मेरा बच्चा रो रहा है फिर भी मुझे ये चीज नहीं देना है तो नहीं देना है.
Okay. So, which syrup can be used in younger children for constipation?
Younger means what age? Or Usually anyway, I personally use, as I told you, macragol preparation like Easylex that can be mixed in water and becomes like an orange juice. Or I use lactulose preparation like maybe sorbilin or Dufelac, etc. But there's no I won't say there's any standard treatment. One has to try and see whatever works for the child. But again, I'm repeating, first diet modification, then medicines.
Okay.
Medicines alone will not work.
Dr. Amola is asking treatment of febrile convulsions. Should we use any anticonvulsants and for how long?
See, for febrile convulsion, again, the main emphasis should be on counseling. Why does the child get fever? It's very easy to say, आप ध्यान रखो बच्चे को वापस बुखार नहीं आए, आगे कभी बुखार नहीं आए, या बच्चे को आगे कभी खांसी सर्दी नहीं हो, वो प्रैक्टिकल नहीं है. So we need to do the counseling for fever. And second counseling is, why does seizure come? As I explained earlier that. So third thing I tell them that febrile convulsion is a common condition. On an average, 2 to 3% children between the age of 6 months to 3 years will get febrile convulsion. But the assurance to parent is that it does not give any harm to the child. Treatment emergency antipyretic. Orally may not be possible. One can do sponging. If you have paracetamol suppository, one can put that. And for seizure, immediate thing is, in case there's a froth at mouth, turn the child sideways so that the froth comes out. And then if seizure is going on for 3 minutes or more, one can use midazolam nasal spray to spray in his nostril to abort the seizure. For the long term, the clonazepam or frisium tablet is prescribed by everybody. I was told by one pediatric neurologist that in UK they don't use it. Studies have shown that you use it or you don't use it, results are still the same. But even I use it, which I realize that if I don't use it, somebody else is going to prescribe. So even I am using it. But to be used for the first 3 days of fever, not indefinitely.
Yeah. So,
And there's no role for typical febrile syndrome.
okay. Dr. Jignesh Cheda is asking how to tackle complaints of nocturia in children 8 to 10 years and above.
Okay. The bedwetting, first of all, what I do is I ask for a urine routine. Usually the clinical picture will tell it's a diabetes mellitus or diabetes insipidus, but sometimes for parent satisfaction, I do ask for a sugar. I ask for a creatinine to rule out renal condition. But again, clinical can tell you with any chronic renal disease, growth will be affected. So these are more for putting a stamp on the paper that everything is okay. And then a urine routine to rule out urinary infection. In physical examination, one must look at the spine also to rule out any spine abnormalities. Having done all this and everything is okay and still the child has bedwetting, there may be a family history of bedwetting that can be assuring to parents. Then I tell the parents it's alarm method, that put an alarm, make the child wake up and make him pass urine. It works in majority. I used to use amitriptyline, dapsonil earlier. Occasionally I do prescribe, but somehow my need for all these medicines have gone down with time. And then there are, of course, antidiuretic hormone, nasal sprays and tablets, diuretin. But honestly, I have not used them so far.
Yeah. So, Dr. Mikal Khanna is asking, is there any unusual symptom of COVID which must be picked up or any red flag signs of poor prognosis in pediatric COVID?
Usually, in pediatric practice, first of all, COVID-19 infection, can occur but not so common as in adults. Complications are also less compared to the older age group. But whenever parents come to me or ask me over telemedicine, I tell them be on the lookout for any unusual skin rashes, the change in activity or behavior of the child, any swelling of the limbs. So what we are looking for is some inflammatory reaction. And of course, if fever is persisting anything, look for CRP, which is usually high with these situations. And any doubt, COVID-19 infection, ideally the child should be otherwise playful, health, active, in between the temperature spike. If between the temperature spike, child is dull, inactive, child has severe loss of appetite, child should be referred to a hospital.
Yeah. So one question from Dr. Mitesh Vora again. There is 4 years old child with severe constipation for 8 days, has to give enema. Child is cranky, fearful with loss of appetite. Sonography of abdomen is normal. Distension of abdomen. Not sleeping whole night. In lockdown, it's difficult to investigate. Can you guide something?
Have you tried macrogol preparation? Like 4-year-old child wanting 2 or 3 sachets of AGLX, and that may help to disimpact whatever the motion is there. Kids are usually scared of enemas, so one can try this oral medicine.
Yeah, so Dr. Vinayak Desai, your question about bedwetting has been already answered, so I think you will have your answer. That brings us to the end of all the questions from all the participants. I would just want to, as sir said, just summarize, or the take-home message is treat the child and not the reports. All fevers don't need antibiotics. Always search for focus of infection before starting any antibiotics, especially UTI, and make sure it is bacterial infection before you start any antibiotics. And always try to differentiate between viral fever and the bacterial fever. The child with viral fever may have multi-system involvement. Mucous membranes may be hyperemic. In between fever spikes, the child would be very cheerful and active. Vidal test is not a diagnostic test for typhoid, but try to use your clinical judgment and blood culture for the diagnosis of typhoid fever. For diagnosis of urinary tract infection, few pus cells here and there does not confirm your UTI. You have to do urine culture, which is a clean midstream urine, and it has to be collected before starting any antibiotic, and the colony count should be more than 10⁵. That's what is the criteria for UTI. Always search for localizing signs. I think this is very nice, sir. Whenever there is cough, think of airway disease. Whenever there is fever and breathlessness, try to think of lung parenchymal involvement. And there is chest pain, try to think of pleural involvement. Whenever there are loose stools, antibiotics is not always necessary. Always do stool routine. If there are pus cells, then only maybe antibiotic is required. And clinical document once again, anti-motility drugs should never be given, like example Lomotil. They should never be used in pediatric patients. And the mainstay for treatment of loose motions is oral rehydration solutions, and metronidazole should never be used in a patient with loose stools unless stool routine shows amoebiasis or giardiasis. And a child with poor appetite, no need to rush with any appetizing medicines or anything. First see the patient. If child is all right, growing well, there is no need for any medicines. Only parents can be counseled well about feeding patterns. So I think I tried to summarize as much as I can. So thank you, sir, for giving your valuable time and enlightening all the family physicians regarding how to manage pediatrics patients rationally. Thank you, sir.
Excellent summary.
Thank you, sir. It was really wonderful.
Yeah, and thank you
And
all the
enlightening.
participants who have joined in today. We thank you on behalf of Kandivali Medical Association. Thanks a lot, sir. Thank you.
Thank you.
So we end the meeting here. Yeah. Okay. Thank you.